Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Si Chen, Physician Director of Practice Sustainability here at the AMA, to discuss the key opportunities and potential challenges of maternal behavioral health-focused models, as well as the importance of including behavioral health as a standard part of providing maternal health care. I'm joined by our guest, Dr. Tiffany Moore Simas, the Donna M. and Robert J. Manning Chair in Obstetrics and Gynecology, Professor of Obstetrics and Gynecology, Pediatrics, Psychiatry, and Population and Quantitative Health Sciences at the UMass Chan Medical School, UMass Memorial Health, Medical Director for Lifeline for Moms, Obstetric Engagement Liaison for the Massachusetts Child Psychiatry Access Program for Moms. Thank you so much for being here today, Dr. Moore Simas.
Thank you for the invitation. Happy to be here.
Before we get started on talking about this really important topic, would you mind telling our listeners a little bit more about yourself and your background?
Happy to do so. I am trained as a general obstetrician gynecologist. I work as a general obstetrician gynecologist. I am, as you said, the chair of OB/GYN at UMass Chan Medical School, UMass Memorial Health. And I have been engaged in efforts to integrate obstetrics and mental health care for about 15 years now. And it comes from or inspired by both a personal and professional sort of passion and experiences. You mentioned the Massachusetts Child Psychiatry Access Program for Moms. We shortened that to just say MCPAP for Moms. It was the first in nation statewide program designed to increase the capacity of OB/GYNs to address perinatal mental health and substance use disorder. I was, sort of privileged to be part of that from its inception. And over time, it's, grown. We started with depression and it's grown to address more severe mental illness and substance use disorder over time. And as the first program, it's something that as we developed it across the state of Massachusetts, other states and entities reached out to us. And so then we developed Lifeline for Moms. And I say we because I've done a lot of this work in collaboration with one of my colleagues, Nancy Byatt, who's a perinatal psychiatrist. So we sort of partnered our perinatal psychiatry expertise and our OB/GYN expertise to bring these programs together. Lifeline for Moms really has helped us provide technical assistance and guidance to other programs that have developed across the nation. So MCPAP for Moms was the first, and now there are 30 states or regions, 2 national programs, and 1 Canadian province that has a program. I've also, had an opportunity to work through some of my professional societies like ACOG to develop clinical practice guidelines, the Alliance on Innovation in Maternal Health to create patient safety bundles, and now currently am leading the implementation of the perinatal mental health safety bundle through our Massachusetts Perinatal Quality Collaborative, PINQUIN.
That's wonderful. That's a breadth of experience, and I'm glad that we have you here to talk about all these very important topics throughout our entire nation. But it's great to hear how you've had some successes in Massachusetts and also throughout the entire nation as well. I know that you spoke already a little bit about the Massachusetts Child Psychiatry Access Program, MCPAP for Moms. And I know you've been on a couple of our webinars here, and if listeners would like to hear more details about this program, they can link to the episode or the webinar description below. But I wanted to speak a little bit more in detail about how MCPAP for Moms has been most impactful for mothers and physicians. What are the most impactful outcomes, especially when it comes to addressing perinatal mental health and substance abuse disorders? Can you tell us more about what you've seen this program do for your patients and the physicians that are involved in their care?
Yeah, happy to do so. So MCPAP for Moms was, the phone lines opened July 1 of 2014. So we're just over 10 years young per se. And it was really modeled after MCPAP. So MCPAP stands for Massachusetts Child Psychiatry Access Program. That program is about 20 years old and it was developed to help pediatricians address the mental health needs of the children of the Commonwealth of Massachusetts. There were not enough pediatric psychiatrists, nor were there ever going to be enough pediatric psychiatrists to address the mental health needs of the children of the Commonwealth. And similarly, 10 years later, we, realized as more attention was being brought to perinatal mental health, that there were never going to be enough perinatal psychiatrists to address the mental health needs of perinatal individuals. So in this model, the model is to increase the capacity of those caregivers, clinicians that are caring for these vulnerable populations, whether they be children or, pregnant, postpartum, or lactating individuals. And I say vulnerable in that, it can be hard to get the care you need or to find clinicians that are comfortable delivering evidence-based practice when you are in a pregnant state. People are often more worried about the fetus or breast milk, and they kind of lose the fact that in order to really have a healthy pregnancy and a healthy child, you really need a healthy mother. And so there weren't enough perinatal psychiatrists. Increasing attention and awareness of the role of mental health as a leading and preventable cause of maternal mortality. And so in this model, it's really to put that expertise at the fingertips of those delivering care to pregnant, postpartum, and lactating individuals. So I'd say one of the real successes is just having access, right, to a perinatal psychiatric expert who can help. I, as an OBGYN, I can pick up the phone. I can say, I have this patient in my office. I'm worried about her for X, Y, and Z reason. And then they'll talk to me so that I'm able to move forward with the diagnosis, with the treatment plan, and really have confidence in my ability to execute that because I've done it in concert with a perinatal psychiatrist. So that's one of the greatest successes is just, Monday through Friday, 9 to 5, having, a perinatal psychiatrist available to help any obstetric care clinician and really any clinician who's caring for pregnant, postpartum, and lactating individuals. It was designed initially really with OBGYNs in mind. However, if you're a psychiatrist or you're a primary care doctor or really any clinician caring for a pregnant, postpartum individual, you can pick up the phone and call. We have found that when we have done some of our research and surveyed clinicians using the line, that they do in fact have increased comfort in addressing perinatal mental health and substance use disorder. And that actually the more often a clinician utilizes the service, the more likely they are to address even more severe mental illness. So when we started this program over 10 years ago, we started it at a time where, ACOG hadn't come out with their clinical practice guidelines yet. The patient safety bundles hadn't come out yet. So we really were a little ahead of when the care standards changed. And so we talked to obstetric care clinicians initially about depression only. And that was a little revolutionary at the time. And so we went from depression, to anxiety, to more severe mental illnesses like bipolar disorder and substance use disorder. And so now we're helping obstetric care clinicians even address bipolar disorder. We're not intending the obstetricians to be the primary, psychiatric provider in the case of severe mental illness, but they can be a bridge, right, until they can get to a psychiatrist or somebody else with more, mental health expertise. And so, I would say access to the expertise is one of the major outcomes. And over time, we've seen obstetric care clinicians addressing even more severe mental illness.
No, I think that's great. I feel like we all know that there's a huge shortage of mental and behavioral health care professionals out there. And for this program and other programs like it to be able to extend those folks' knowledge and capabilities out to a larger patient population is always a good thing. But not only that, I think that comfort level that you've rightly noted that clinicians have in calling upon their psychiatric and behavioral health colleagues, it just makes care so much better, more fulfilling for the clinicians involved as well as the patients, I think. So a wonderful program, and thank you for sharing those details.
Yeah, and I would describe the model somewhat in the sort of parable of, if you give a man a fish, right, they eat for a day. If you, teach a man to fish, they'll eat for a lifetime. And this model is similar to that in that when you pick up the phone, so I, as a physician, call the psychiatric physician on the other end, they're not going to take over the care of the patient. What they're going to do is teach me how to care for that patient. And so when I call the first time, I may hear that guidance. When I call the second time, I may hear that guidance again, tailored to that particular individual patient. And then the third time I have a similar patient, I may not need to call, but if I feel like I need to, I can do it again. And as we've said, when we first started, we thought, well, we would train everybody up and then they wouldn't need to call. And, in an ideal world, maybe we'd put ourselves out of a job. But what has in fact happened is, in fact, people are taking care of more complicated situations and still, I think, find comfort in having the support to do that.
Yeah, and I think not only does it you find comfort and support in having that sort of safety net, if you will, for your own personal psychiatric and psychologic knowledge base, but also I think it decreases that moral injury that we get when we feel helpless in terms of trying to help our patients who have more complex issues, like what do I do now? I don't feel like I have the resources. I think that this program definitely gives you those resources at your fingertips. So I think all of those things are what we need in this world where we don't have enough psychologic and behavioral health professionals out there.
Yeah, I agree. We try to do it through a number of different pillars. One is, of course, just education and training. Like if we'll come to a practice, we'll come to a grand rounds, we'll come to society meetings to provide sort of more typical didactic education and to try to convey an understanding of how you engage with the program. Again, we don't take over patients, but we help provide care to the patients through the clinicians. There is the consultative part that I just talked about, which is that doc-to-doc consultation over the phone. In Massachusetts, which is not the case in all of the programs, there's also the opportunity for a one-time sort of patient to MCPAP for moms psychiatric consultation, in which that is a formal consultation, which then recommendations feed forward to the original provider that called and asked for support. And then there's a live active, updated inventory of all the behavioral health resources across the state. And so we can partner based on, geography, insurance type, whether there's a language preference, and trying to get the patient into therapy as one of the first line treatments recommended for, like for mild to moderate depression, anxiety, et cetera. And then we also provide technical assistance. We'll work with practices if they want to figure out how to integrate mental health more deeply into their obstetric environment. So through those different pillars is how we try to, help that support, decrease that moral injury, and just over and over, just say like, we are here, call us.
That's great. And I think you've given us a great segue into sort of looking at the nationwide lens. With the development of the perinatal psychiatry access programs nationwide, what do you think have been the biggest challenges and successes in sort of bringing that model to scale? And how has the national network of access programs sort of furthered these efforts?
Yeah, so I'd say from a challenges perspective, I think of kind of three major challenges. The first one I would say is awareness and engagement. The second I would say is sustainability, especially as it relates to finances. And the third is just the mental health workforce. So from the first challenge around awareness and engagement, this isn't a situation of if you build it, they will come. Through the national network, one of the most common questions we get is, how do we make sure OBGYNs or other persons, clinicians caring for pregnant and postpartum individuals know we exist? And that it's a lot of boots on the ground effort. It's inventorying all the practices across the state, being very purposeful about, going to them, engaging them, making sure they're aware of the program, making sure they're aware of how to interact and engage with the program, making sure that their awareness is enough that in the moment of potential crisis in your office, if you're worried about somebody, that's who you're going to think to call. And so that the challenge number one is just making sure people know your program exists and that they're going to pick up the phone and call you, because it doesn't help if the programs exist if nobody picks up the phone and calls, right? And so then the second challenge I would say is around the sustainability piece. The MCPAP for Moms program won a lot of awards early on. It was acknowledged as a sustainable, kind of reproducible, innovative service delivery model. And for, sort of a relatively low cost, less than $1, per month per pregnant individual in Massachusetts, we would serve all these individuals. And if you look at the cost of untreated perinatal depression at about $32,000 per mother dyad care, it's a tremendous cost saving. So, from back of an envelope and, public policy perspective, it makes a ton of sense to have these types of programs. And so, of the 33 programs across the country, they're funded in various different ways. But with MCPAP for Moms being the first and it having, that back of the envelope calculation, and the elected officials we have in Massachusetts at the federal level who are tremendous advocates, there was legislation put forward, and 7 states initially were funded through HRSA, and then subsequently, and that was under the Obama administration, and then there was subsequent legislation under the Biden administration that continued to fund those programs and brought additional programs on board. But especially for those that are funded through federal dollars, there's always this kind of wondering of sustainability, like, will they be able to continue? The Massachusetts program it's basically funded as a line item in the state budget, and half of that is funded through a legislative mandate to the private insurers, because most of these programs are insurance agnostic because they aren't patient to provider interactions, they're provider to provider interactions. So there's not a reimbursement there. And so there, you do need to get creative in how you fund this. Again, if you look at the cost of untreated mental health illness versus doing this, the cost is much less. But still, as people are making these decisions, we always wonder and are grateful to our various colleagues, especially at Maternal Mental Health Leadership Alliance, that are constantly advocating and bringing attention to this issue and how these programs really support that. And the third challenge I would say is, the mental health workforce. Which is just, it's not enough, right? There's such a need around mental health and behavioral health, and, access programs can only do so much. I mentioned earlier that psychotherapy is the, first line treatment for many mental health conditions, especially those that are mild to moderate. And yet sometimes pharmacotherapy is what happens initially as a bridge to getting to therapy, because the psychotherapy workforce is not as much as we need right now. And so when we first started MCPAP for Moms, we said we'd pick up the phone in 30 minutes and we'd try to get your patient into a therapist within 30 days, essentially. And those waits are much longer, especially now post-pandemic. And so that's one of our challenges, is needing to, the goal of MCPAP for Moms is to connect with care. And so we need some of those caregivers to be able to connect to. With regards to successes, I would say the fact that, MCPAP for Moms was the first in nation 10 years ago, and now there's 33 total programs. I would say one of the successes has been that, reproducibility, replicability, and that, these programs still exist. So, they're utilized, they're valued by providers. And what we do at the national network of access programs through Lifeline for Moms is we connect all of these programs together. So, I said one of the first challenges was awareness engagement. The second was sustainability. And so we meet monthly and we talk about, like, how do we address those things? We don't need anybody to recreate the wheel. We learn from each other. And although every program is different and every program within a state has its own challenges, they're similar themes, and we can learn from each other and share our approaches to that. Share our approach to advocacy, share our approach to engaging providers, and share our approach to marketing and awareness, for example.
That's great. I know you just mentioned Lifeline for Moms, and I know it plays a critical role in advancing integrated care for perinatal mental health. What kinds of other innovative strategies or tools have you found most effective in achieving the integration, both at a clinical and at a systems level?
Yeah, so Lifeline for Moms it sits at UMass Chan Medical School. It has been a collaboration between psychiatry and OBGYN, and yes, the national network is in Lifeline for Moms, and also it has been kind of our research home and our implementation assistance and innovation hub. And so in addition to helping kind of create these programs and providing guidance, Dr. Byatt and I have also, we root a lot of our work in research and outcomes and implementation science. And so when the very first perinatal mental health safety bundle came out in about 2015, it was the Council on Patient Safety that put forward that bundle. And it was just like the bundle was created and I was honored to be part of that team. But it was one of the only bundles created that didn't then get implemented, right? So then we had to ask ourselves why, and was very grateful at the time. ACOG then put together an expert work group and did focus groups, went to OBGYNs and said, like, what is different about this bundle? Why are people not ready to implement it? What would need to change in order for that to be the case? And so what came out of those focus groups were, people wanted toolkits. They felt like they weren't trained in mental health, and so wanted kind of didactic and trainings. They wanted to understand how to implement it into their practices. And so with that information, we then were able to apply for funding and was granted it through CDC Foundation, NIH, and ACOG to create exactly those things. So we created a toolkit focused not just on depression, anxiety, but more severe mental illness like bipolar disorder and postpartum psychosis. We created e-modules that were funded through NIMH and now sit in ACOG's learning management system to address that. We didn't train in this, we need didactics. And then we created an implementation guide. We had been funded through the CDC to work within practices in Massachusetts to implement mental health care in obstetric care environments. And so we took our learnings from that, created an implementation guide, which was both for the study. Myself and Dr. Byatt went into practices along with our team to do that, but we knew that wasn't sustainable. And so we then created either a guide that was kind of self-guided or was accompanied by videos in which Dr. Byatt and I would walk people how to do this. So the toolkits, the e-modules, the implementation guide, that whether self-guided or with video support, were some of the innovations that we put together, some of the resources. And similarly, through Lifeline for Moms and through the network, we would provide technical and implementation assistance to numerous states, which we have done. And now through some of the work that is funded through PCORI, are doing that to train other access programs to then provide technical assistance to other practices in their states.
Thank you for sharing that experience. I think it's really helpful and hopeful for folks to know that it's sort of like you initially sort of had a roadblock there where your package wasn't adopted, but then you work through all of those obstacles to achieve something that's really sounds like it's having a great impact on patient care, not just at your institution, but statewide and nationwide. So that's awesome. I did want to rewind a little bit and back to when you discussed the financial sustainability portion of things. I know that you discussed the HRSA funding and some other grant making. And I know that the federal governmental payers, CMS, they've been launching some behavioral health specific models in OBGYN. But I wanted to get your take on why it's so important to continue to test some of these models, especially at a federal or state governmental payer level.
Yeah, it's so, I think it's interesting if you look at healthcare in the United States and how it's funded, it's complicated. And if you compare it across other sort of resource fortunate countries across the world, there's a lot of areas in which the US doesn't get the highest marks. But one is actually in trialing, different innovative models and approaches to payment and alternative payment systems. And so where a significant portion of healthcare and reimbursement for healthcare comes at the federal level, I think it's really incredibly important that they are involved in evaluating different approaches and different models to things. The other thing to realize is that how prenatal care and postpartum care is delivered hasn't markedly changed in over 100 years. And how it is delivered, the sort of cadence of, a visit every 4 weeks until, through first and second trimester, and every 2 weeks through third trimester until full term, and every week until you deliver. And then, a visit at least at 2 weeks postpartum and 6 weeks. That hasn't changed in 100 years. And most of what happens in that time isn't really evidence-based. And so there's, people across the country, Alex Peel is one of the people that comes to mind that's really kind of questioning that. And I think, with the sort of versioning of remote medical monitoring, with some of the changes that have happened over the pandemic, with some of the new technologies and the role of AI, like there's just a lot of opportunity for innovation. I think we know, given the maternal mortality crisis and the disparities in obstetric outcomes across the nation, there's so many reasons to pursue a different way of doing things if we want better outcomes. And having partners in our federal and governmental agencies and with our payers is going to be important to pair that and to incent the outcomes that we really want to see.
Thank you for that insight. And, wrapping up, are there any other pearls of wisdom you'd like to share for our audience members?
I guess what comes to mind is, we still treat mental health quite differently and think of it quite differently as physical health, as opposed to just talking about health. And that is an arbitrary distinction. And on the one hand, it's important to call it out separately and bring attention to it. On the other hand, that's part of this, stigma that is attached to it. So the more we can partner conversations of health and assume and call out mental health as part of that is incredibly important. To decrease the stigma is incredibly important. I think the stigma around mental health is high. The stigma around mental health associated with pregnancy, which historically has been thought of as the happiest time in somebody's life, when it's actually really hard, is important. So to really open up conversations, to not assume with pregnant and postpartum individuals that they are like in the glow and throes of, pregnancy and motherhood, but to just ask like if they're really okay and if there's something that you can do to help. One of the treatments that any one of us can help a pregnant or postpartum individual have access to is sleep, right? The sleep deprivation is real and can have significant negative impacts on mental health. And so being able to help a family member or a friend, allow them to get some sleep, you can really be part of a therapeutic experience for them when they're struggling.
I really appreciate that you highlighted that, even though we know that there's a stigma to mental and behavioral health in general, which I think is changing, but is still there, for you to highlight that, in the perinatal period, folks are even more vulnerable and at risk, I think is a very important point, especially given the fact that we all do sometimes say, hey, this should be the most happiest part of life, if you will, but to point out, sleep deprivation and all the other factors going into it, I think is really important. So I thank you for highlighting that. And I thank you for being our guest today. This has been a wonderful conversation, and thank you for all your insights and your experience, sharing your experience with us today. So appreciate this discussion.
Thank you for inviting me. Really honored to be able to be here and share some of these experiences.
Dr. Tiffany Moore Simas has been our guest today. Please check out the episode description to explore the resources mentioned in today's podcast episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.